What's
Oh,
going on, guys? So, welcome to today's episode. I'm sitting down with Ian Kaplan, where we're going to be talking about some of the research on back pain and treatment protocols. So, first of all, Ian, thank you so much for jumping on the episode. I'm really excited to have you here. Can you just give yourself a little bit of an introduction for those who aren't familiar with you and some of the work you've been doing?
okay. So my name is Ian Kaplan. I was trained as a chiropractor. I have a degree in chiropractic medicine, but currently I work at Hybrid Performance Method in Miami, Florida. Um, Working on a bunch of stuff related to the product, the core training and nutrition business, and kind of the software it's delivered on. And I also co-authored a book with Steffi Cohen about back pain. So I think that's the relevant thing to this conversation.
To dive right into it, can you just talk a little bit about the prevalence of back pain and why that might be the case?
Prevalence. Back pain is one of the most common causes for disability, one of the most common causes for missed work days, and has some of the highest cost of healthcare in the world. It's something like 7% prevalence, meaning like I think that those numbers are old, a few years old now. Just at any one given time, 7% of people have back pain. Again, those are estimates. I don't want to speculate as to why, because there's a lot of conjecture and hand-wavy explanations as to why. Pain is a fact of life, and back pain, particularly can be scary and can last a long time. So yeah, I don't want to make. There's lots of reasons people can assume or can guess based on, whether back pain has gotten worse. It definitely hasn't gotten better. We're pretty confident it hasn't gotten better. Are we observing it more? Is it reporting to clinic more? Again, those are hard questions to answer. I think just the plain example is a lot of people experience back pain for many different reasons. So it kind of all gets lumped into this very big kind of bucket of presentations. So active people have back pain sometimes, inactive people have back pain possibly more often. People in developing countries have back pain. People who, in highly, in much wealthier countries also have back pain. So yeah, it affects everybody. So my interest is less on why it exists and more what to do about it. And those aren't always the same question, right? It's not always a root cause analysis that needs to happen, especially when causes are complicated or uncertain.
And so, what are some of those obstacles that you run into when treating individuals with low back pain?
So I want to preface it that I don't really treat anybody right now. I just wrote about it. I don't practice, so don't reach out to me and ask me if for a consultation or whatever. But working with people who've had back pain, research, being around a lot of high performers who've had back pain, who've kind of gone through it, we tend to focus on the obstacles that are related to learned behaviors around pain that lead to people protecting, right? So some of the things that people need to do to get back to doing the things that are important, like having a kind of a positive framing of their circumstance, even though it's hard and it's painful, and also getting back into graded exercise. Those, we find obstacles to those based on people's fears, their uncertainty about the future, things they've learned, things they've been told about their pain, by people who may or may not know exactly what's going on. All those serve a purpose normally because there does need to be some protection, right? There is some sort of reduced activity that needs to happen, especially if there is an injury. But there needs to be a plan back to the previous level of activity at some point. And generally, we think that is sooner rather than later, especially because people tend to be overly protective and resort to overly kind kind of overly reduced activity levels, which can then harm recovery in the long term by not reconditioning people back to their previous level activity, and then you end up in this cycle where you end up basically not doing anything, and then at some point in the future when your pain goes away, you go right back to your previous level activity and you're not prepared. So really think about preparation versus protection, and where people are in that kind of life cycle of an injury, rather than tissues that are broken, tissues that need to heal. Those might be relevant and part of the picture, but those aren't necessarily helpful or a complete context for a person to engage in an activity program that will actually help them kind of get back to the things they normally do and prevent this thing from becoming a recurring or chronic thing, which could happen if they kind of fall into this kind of protective mindset. Make sense?
Yeah, absolutely. And that was something that's kind of interesting to notice. Is I wrote a review paper probably about a little over a year ago on low back pain and effective treatment modalities. And there was a handful of papers that I reviewed. And the one was a network meta-analysis in 2020 by Owen and colleagues.
Yes, I know that one.
Yeah. And that was kind of the interesting thing, is this kind of big shift in paradigm from, if you're injured, probably take it easy, relax, try and avoid pain. Whereas now it seems like people are trying to ramp people up into a more, like you said, graded exposure approach to get them back into physical activity of some sort, and kind of ramp them back up and build tolerance over time.
Yeah.
What was the catalyst for all of these this big paradigm shift in pain management?
I think the paradigm shift is that the evidence for the other paradigm was terrible, and that the better the more robust the research, and the more rigorous the kind of the scientific standards, the smaller and smaller effects you saw, until you saw no effect, and then you had to explain that. Right? You saw a huge, well-controlled, kind of multi-arm trials that are really trying to isolate the effects of specific treatments, and they found no specific effects. They can't, or if there is an effect, the likelihood that it is large is so tiny that you need some sort of, you need to update your priors about your, about kind of, you have to update your prior beliefs about what is, what this causal behavior is. So if you think that this specific thing is leading to this outcome, and then you have large populations of people that fail to that reject that kind of hypothesis, then you have to revise your hypothesis to adjust for that evidence. And the evidence that we saw was that a lot of things tend to work, and they work moderately well. Time works better than anything else, pretty much. So even when you just waitlist people, they tend to get better. So that kind of throws a wrench into people's idea that their specific treatment is the best thing ever. And then even when you give people a lot of different treatments, they all tend to do pretty well. And then you try to figure out what are the common things in these treatments that actually might be contributing to the benefits. And then you end up having to step back, because these treatments are not, especially in low back pain, they're not single mechanism of action. They're not like drugs. They're multi-dimensional therapies, and it's hard to isolate specific effects. So you need a treatment model that doesn't really care about specific effects, which is much more about whole person kind of positive patient-centered care in medicine, which is just like deal with the person in front of you, deal with their expectations, deal with their beliefs, and give them a plan forward, right? After you screen for serious pathology, but that's rare, and especially when we deal with active people, that's very rare. So you come up with a model that is much more psychologically informed, that is cognizant of tissues and biological things, but doesn't put them on a pedestal above other things. We really put social emphasis on a pedestal. We care about whether the person will actually engage in this program, right? Because we find that when people participate in activity, it's better than them not participating in some activity we think is better. When people are motivated, when they have high expectations of relief, that might actually be one of the contributors to placebo effects, is that they actually believe they're going to get better. So if we can replicate that without, the side effect of giving expensive, relatively ineffective specific treatments that might actually have harmful side effects, either, physiologically or psychologically, then we'd rather do that, because really the best intervention is the most minimally invasive intervention that gets the most benefit for the most people. We're talking about population level stuff, which is really, when you have the conversation about research, that's really what you're talking about, is really, right? How do we capture the most people in general recommendations, and then some people will not fit those general recommendations because they're at the edges of the distribution, and then those are the tough cases that medical practitioners really have to deal with. But right now, especially musculoskeletal care, I think people are being overtreated and overdiagnosed and over-medicalized for socioeconomic and kind of physical activity-related issues. And that is ultimately harmful in the sense that it's expensive. It introduces them to treatment that have side effects, that have harms, or risks of harms that might not necessarily be. The patient might not choose them if they actually knew the harms versus the likely benefit. And then there's narratives that come with it that may or may not also be harmful for the patient long term, right? They might adopt this kind of fragile mindset that they need treatment, that they need to be fixed, that they need this and that to function, right? And that if something happens, it's because they failed or something's broken, right? We don't know how much that actually influences certain people, because that's kind of a subjective thing. But my thing is why, coming from someone who doesn't have an economic incentive to overtreat and overdiagnose people, as an intellectual pursuit, my idea for the best practice treatment is the treatment that costs the patient the least, that gives them the most benefit over the long term. Right? I kind of went on a bunch of tangents, but that kind of summarizes the paradigm shift. And the paradigm shift is shifting, hopefully, but it hasn't taken hold in much of medicine. It's only in kind of academic circles. It's, on the fringes of people in certain, types of care models where they can afford to do that. It's more in some countries rather than others. And it's in some professions more so than others. So I think of it more as kind of a fringe but emerging concept in a world where evidence is disseminated more easily via like Twitter and open source journals, and people are getting a little bit more savvy about reading evidence. And people can kind of break down silos of knowledge and really kind of ask better questions if they're prepared to critically appraise evidence. But most people are still doing cookbook medicine from, the 20s and 30s. That was never population based, and there was a big push in the 50s and 60s to make it more population based. Replicating a push in the turn of the century to make evident, medicine not about snake oil sales, right? Not kind of this witchcraft apothecary fake kind of. It's like, empty theorizing about these models about how the human body works, very much like, because that was what it was until the 20th century. It was very non-scientific. It was very people coming up with ideas about how the body should work and then reasoning about treatments based on those ideas without validating that they work or not. Right. So I think we're in a cycle of revival of what it means to be evidence-based and what it means to be patient-centered, because those are kind of buzzwords, but they have weight behind them. And there's places for people to go to learn about it, even non-practitioners, I guess, which will likely be most people in this conversation. Um, but but I think it's a lot of work, and it's more about systematic change than about a bunch of research being published, which is the hard part. But as active people, we are in a position to take that research to heart and do something about it. People who are less fortunate in the developing world and in communities that don't have access to a ton of activity, are need more help from society, right? And are more at risk of the costs of bad healthcare.
Yeah, you definitely brought up a lot of really interesting points. One of the points that kind of stood out to me was just how deeply rooted some of the dogma is around research and how tradition can kind of impact the utilization of different modalities for treatment, and bringing up a different approach potentially can be met with quite a bit of resistance. I know that I've certainly communicated with different clinicians that athletes have been using, and they'll just be using, let's say, manual therapy. And I'm like, are they giving you any sort of exercise to do, anything like that? No, just manual therapy. I'm like, oh, okay, that seems kind of strange. So then I talk to them and I'll ask them some questions. And most of the time they're pretty good. But every now and then I'll get someone who's really just hostile and aggressive when I bring up, you know, other things or ask certain questions. And they're like, oh, you're one of those quacks. And I'm like, I'm not a quack. I'm like saying that, but like, you know what I mean?
Yeah.
If I'm bringing up something like, you know, the utilization of different exercises, or you know, I'm asking them what kind of conversations they're having with their athlete around pain and what that means and things like that. And they're like, oh, you're one of those guys. And I'm like, oh, I guess. I don't know what you're going to mean by that.
No,
There's quite a bit
as
of.
as a chiropractor, you get exposed to a lot of crazy people, and then they think you're crazy, and then you're like, am I actually the crazy one? Like, am I taking crazy pills? And then you get out into the real world and you're like, oh no, they're actually insane, and and they believe crazy things, and for either through force of personality or through shared delusion, they convince patients of their ideas about the body. I have no idea. I have no idea how it works. It really shook me in chiropractic school. I'm like, people do this to people, and they have licenses to practice medicine, and then they think exercise is a dirty word, and they think talking to patients is beneath you and a waste of time, you know, and instead it's all about the delivery of the divine treatment that you have been trained to give and bestowed upon you by some messiah-like figure, and that you're not responsible for what happens after because you've done your. It's like there are crazy things and all borderline cult things. So I tend not to focus on that anymore because it's exhausting. But for someone we are spoiled as people who work with athletes, where we kind of all assume that that's like the right thing to do, is to, when you're dealing with an athlete, they get exercise, you talk to them, right? Their psychology is important. Their optimism about their ability, about their body is important. It's important that they're diligent with their recovery and everything, and that they voice their concerns. But that's not a given. And there's a fine line between a manual therapist, like just someone who thinks of themselves as a manual therapist, and a clinician who also does some manual therapy, you know, to calm patients down, to make them feel safe, you can actually reaffirm people's confidence in their body if you give manual therapy in the right context. But if you are, you know, have some bizarre story about why you're giving the manual therapy, then that's not helpful. It might not harm an athlete. They might actually shrug it off, or athletes can have weird beliefs too and still be fine. It's just a weird thing to have to deal with when you have an athlete who has a team. I get what you're saying, because I've seen it before. You have an athlete as a team, they have some great people around them, especially on the strength coach side, and then they bring in somebody who's just a lunatic, you know, and they're like, how do we deal with this guy? Like, how do we make sure, like, or this girl? I was like, why are they here? How do we make sure that they're not, you know, doing more harm than good? how do we not confuse the athlete, right? How do we not send mixed messages? That's a problem I don't know how to solve.
Yeah, you also mentioned something about logic and making these kind of seemingly logical conclusions, and that's something that I found to be pretty interesting as well. Just even having some discussions with people either on social media or in person with different peers, and sometimes there does seem to be like an over application of logic in the absence of evidence, right? And it sounds kind of counterintuitive to say that utilizing logic is bad, and I wouldn't say that it's bad, but sometimes you can kind of rationalize the situation and be like, oh yeah, well this makes sense. It's like, well, what makes sense doesn't necessarily mean that it's true, like gravity to me is baffling. Like, you know what I mean? Like when you actually explain gravity, you're like, oh, that's fucking bananas. But at the same time, it's true. And so sometimes things that seem like they make sense, seem like they're kind of coherent on the surface, when you probe a little bit deeper, you're like, oh, okay, maybe that's not exactly true, especially when we make some of these like mechanistic claims, right? You see this a lot in like hypertrophy studies where they're like, oh, we found that, this vitamin and this mineral or this specific application of training did this. And it's like, okay, sure, but from a mechanistic standpoint, that might be true, but then let's look at how that actually translates into real world results. And you just don't really see anything meaningful. And so I think that can kind of be dangerous when you try and apply things maybe a little bit too broadly, or if we try and rationalize things sometimes, I think it needs to be kind of overlaid against, on top of the evidence and say, okay, even though this makes logical sense, how does this actually like pan out in the real world? How does this actually pan out when compared with what we know about, back pain, communication, and individuals like perception of pain and the experience? And I guess this kind of leads into my next question, which would be the biopsychosocial model of pain, and potentially just giving a little bit of a background on what that is and how that influences an individual.
Yeah, so that's an interesting question because, I mean, that goes back into a couple points. Is like, people are great at generalizing. That's why it's part of how we learn. And I think we get pretty good at it because that's how we apply knowledge in one situation to knowledge in another. But that's not a way of truth seeking in the world. That's a way of navigating it so that you're not constantly surprised, and so that you can learn enough to get by quickly. And in the absence of really rigorous critical thinking, that's all you really have is kind of generalizations, from one situation to another. So you can't really blame people for that. They're using the tools they have to deal with uncertainty, right? So the hard part is giving people different tools and different data sets is really hard. That's why it takes years to build really robust data sets. And we're not very good Bayesians, right? In the sense that our Bayesian probability is like your prior beliefs, modified by new evidence should change your posterior beliefs. We generally heavily weight our prior beliefs against new evidence, and we heavily weight evidence that's close to us rather than large amounts of evidence that are distant. So if we see a lot of people far away doing something that's not as powerful to us as seeing one person really close up that we get to see and feel and touch. So that limits our ability to cut out the noise in our observations. So I think the only thing you can do is know that exists, and it's just part of a good education, right? That's well-rounded in some math and some philosophy even, right? I think you and I would both be biased that even coaches need to be able to read the method section of a research paper, which a lot of people can't because they just don't have like statistics. So it's like a foreign language. It's like you don't know what a p-value is, you don't know what a normal distribution is, you don't like the basic language of modeling the world in a quantitative sense just doesn't exist for people, right? Because they either didn't take statistics in high school or they forgot it, or they learned to do normal distributions on a calculator, learned what it meant for in the real world. So they have no tools. So all they do is sit and watch a person, whatever, do a lift or whatever, and think about it, and think about how it must work in this way. And sometimes that's helpful. I mean, I don't know. That's how you generate hypotheses, but then you have to test them. And then there's other reasons why people will position their hypotheses as facts, rather than as conjecture or as something to be tested, because again, people want to seem more certain than they are, or want to believe in their certainty, or don't want to deal with the fact that they could be wrong, for personal or professional reasons or whatever. So I think it's more about a culture of accepting that uncertainty and empowering people to learn the things that help them deal with it, which is a different type of education than sitting around and watching people squat. And then it's almost the same conversation as the medical thing. It's like, you can't just learn the biomechanics and the anatomy. That's part of it, but you also need to learn these mental models for thinking about, right, cause and effect in the world, right? You need to, have some counterfactual reasoning and not just kind of if-then reasoning, right? It's like, what if the effect happened without the cause I believe that causes the effect? What if I still saw the effect, right? How do I isolate the effect? Yeah, so that's kind of where my head goes with that. These are all hard problems to solve, and I just think working on them requires a change in perspective for educators. I hope at hybrid we're doing a little bit of that, and we can always do it better. I mean, we're trying to do more on the education side. Yeah, and I hope, and also the point of the book was to kind of do that too, was just to tell a story, a more empowering story, and also to give people a picture of the current state of affairs, of the evidence, without getting too much into the details, because the details are, while exciting for some, are not as relevant for everyone, and that would be the scope of another book.
Yeah, no, that makes sense. It's funny actually, because I've definitely found that probably for the last, couple of years anyways, the thing that I'm really interested in is so not applicable to my athletes. You know what I mean? It's just like intellectually interesting. You're learning a little bit more about mechanisms, and you're learning more about like this, and it's like, if you apply it, it's going to maybe have like a 0.00001%.
Yeah.
The results you're going to get are from like proper training, proper sleep, proper diet, and then just being in a good headspace and minimizing stress and stuff like that. And so learning how to maybe apply like BFR training to your biceps or quads, like, how much of a difference is that going to make? I don't know, but it's definitely.
Yeah.
So I get what you mean about like not being super applicable to most people. But that actually brings me to another question, kind of coming back to different treatment modalities and the difference between you were talking about kind of a clinician versus a manual therapist and in that fine line. So what is the role of soft tissue work? What is the role of manual therapy? And then also just kind of bridging into like potentially muscular imbalances and motor control issues and that relationship to pain and how that potentially be treated as well, or not treated, but like maybe addressed to some degree, utilizing exercises in manual therapy. I don't know. There's a lot. But.
Yeah, it's a bunch of things. So I'm going to tell you my perspective, because I don't think there's a right way. There's not a right answer to this. Again, mostly because I acknowledge that we don't know what's going on. And back to your point about like a lot of the intellectual development past a very certain point, like there's like diminishing returns on like learning, and people refuse to believe that for some reason. They're like, every new paper I read should translate to my athletes, and I'm somehow a better coach because I apply this paper to my athletes. I was like, no, like you might spend 10 years getting a little bit better at answering one question, which means you might actually just throw out something you did 10 years ago, right? That's not the point, right? The point is answering big, tough questions more confidently over time. And the over time part is the tough part to swallow. There are industries where papers are more practical, which is kind of more what I'm into now, where it's like, much more on the engineering side of things. There's like, because a paper was a state-of-the-art model or or a system, and then you're like, okay, we can try that system because it fits our use case, or it doesn't, we have to tweak it. But that's not kind of, and also obviously for drugs too, it works, but for kind of more open-ended, again, multifactorial things like pain and performance is much different. But back to the role of manual therapy. We address this in the book. My bias as someone who doesn't do manual therapy for a living, who never really enjoyed doing manual therapy, even though I spent a bunch of years at chiropractic school doing it all the time. I don't think it needs to be. Like, I know chiropractors are manual therapists, essentially. There's like an equality there. Like, people think chiropractor equals manual therapists. And I know a handful who don't do any manual therapy. And there's like, I just don't do it in practice. People don't come to me for it. You know, I'm like a pain and rehab clinician or whatever. I just help people, you know, with their back pain or post-surgery or whatever. My thing is, I don't want to say I'm against it. I'm saying personally, if I were to continue to practice, you know, there's a difference between touching people like therapeutically or diagnostically, is a thing, and doing manual therapy like for relaxation or for a spa treatment, right? Those are kind of two different things. So I'll just stick to, because I get like athletes like, you know, massages and sports massages, and they feel better when they're done, and it's kind of part of the routine. I don't like the idea that it's making any permanent change, because that's just not sound scientifically. And you can explain why athletes like it in very different, much more easily justifiable terms. For manual therapy for pain is different. Again, hard to justify in terms of kind of biophysiologic terms. People try very hard to do that. And again, the more rigorous the evidence, the more it kind of falls apart. Graston is a really good example of that. There's some great meta-analysis that are just trash. And then when Graston comes out with one, it's like, it looks all right. And then when you cite the same papers, they're citing all the worst papers that make no sense. And they're tiny, and they're funded by Graston people. You know, they just make no, like the papers that they justify that show some effect, one, show very small effects. Two, are just, the methodology is bad. Like, there's no error, you know, there's no confidence intervals. Like, it's barely like, it shouldn't be published. They're published in these chiropractic journals that have no standards, that are likely predatory, like they're pay for publish, and then they hold those up as evidence. So there's a whole conversation about about reproducible evidence that we can have. So like, you don't trust evidence just because it's evidence. A lot of evidence is bad. But my point with that is, there's a lot of people waving papers around that justify their manual therapy thing, but none of those are very good. So we can say that, but that doesn't mean you can throw out manual therapy as something that's viable. Again, it's the context. So if you want, so my thing is, while I don't think it's necessary in any case, like it's not, we can safely say that it's not the magic thing that will get some people better that they've been looking for their whole life. Especially when I have in mind athletes with pain who need to get back to their sport, which again is kind of the center of this conversation. But if you are going to do some manual therapy, you can frame it in a context of showing people what they're tolerant of, helping people calm down and reduce their kind of threat level or their pain, so they can then do some activity and then build themselves back up so they don't need the manual therapy anymore, right? So it's kind of like, it's helping people build momentum and helping reaffirm that they can tolerate the rehab program, right? It's preparing people for that. I think that's fine. Some people are even against that you can get away without doing that, and that if you're just, charge people for that, then you're just overcharging people. Right, but like you can see how it's this kind of, it's supplemental to the main thing, which is really this conversation with a person. And in a sports rehab context, the activity program that gets back to their sport, right? So when the person is just a manual therapist, they are on the sidelines, right? That was my thing. It's like, why do you just want to be like this kind of ancillary player in someone's care? Like, why don't you want to help, right? Why don't you want to be their coach? right? They're the quarterback. Why don't you want to be their coach as the clinician, right? And not, I don't know, the, I don't know what an analogy what would be. Where you would be. You'd be like, the guy who hands them, the game ball or something. Make sure all the game balls are inflated the right amount. I hope that answers the question.
Yeah, it does. It's definitely like a tricky subject. And so in terms of getting an athlete back to sport practice and back to competition, what might that look like? Not necessarily from like an acute injury standpoint, but kind of more broadly speaking. So we have someone who's experienced some pain, they're coming in, they're seeing you. What would a general progression strategy look like? And what would kind of the basic underlying tenets look like?
Okay, so we actually frame this in the book, and we frame it pretty conservatively. My first thing would be like, how much activity actually needs to be reduced? Can they just slightly modify their activity to tolerate whatever's going on and let it resolve over time? Because again, we know time. Again, this is a clinician talking who like is confident that this is self-resolving, has seen it before, know the patient is capable. So in that general, which is most of the time, so the first question is, how much do we actually need to reduce activities? Like, can we maintain a relatively normal level of activity and just modify some things to make them more tolerable temporarily, right? And then slowly unmodify those things. If there really needs to be some reduction in activity, like something a little bit more serious, then we have this framework in the book of, right, first, deliver a positive experience of movement, which is a Craig Liebmanson thing. He says it all the time. Which is, right, if the person is fearful or unable to move in a certain way, get them moving in ways that are not painful, right? That they can move, right? And that's both in the sense of like biomechanically, like if a direction hurts or if some specific pattern hurts, right? Find ways that don't hurt. If moving in general limits their ability to exercise, find exercises that don't hurt that they can continue exercising with. And that's where you have to be creative. Like, there's no reason for people, like if people are in an endurance sport or need some level of conditioning, they still should be able to do some conditioning. Like whether it's a bike or, I don't know, a hand bike or, sitting and, and waving their hands. I have no idea. There's something people can do to move around, or do that. And then the next thing is graded exposures, right? And then we start reintroducing in safe and progressive environments the thing that hurt, right? And both at a biological level, exposing the tissues to some stress so they can adapt, as well as exposing the person to that threatening environment so they can work through it and de-escalate the threat is really important. I think in general people do that naturally, but if there's some fear of protection lingering, then you kind of need to address that deliberately, and that's really something for a coach has to be careful in doing that, because there has to be a deep amount of trust that the environment is safe, which is generally easier to do in a clinic or in a rehab environment, like with the person in the collar shirt that says rehab specialist or doctor, like, right, that signals the people that they're in a safe environment, that they fill out a bunch of health forms and that their insurance is paying for it, like that. There's a lot of kind of ritual in the clinical environment. Craig also calls that the tyranny of the visit, which actually might harm people, that they're in a medical environment, they're getting medical treatment, there's something wrong with them. But on the flip side, it can make them feel safe, potentially. But at the same time, you want to get them to the point where they can feel like they're training around, in ways that they used to train, right? And that's kind of the last thing, which is the return to load. Is like eventually you got to load someone up again, right? In the patterns that used to hurt, right? Which is whatever's important to them, right? And it doesn't have, and if it's not important to them, maybe you don't have to do that exact thing, right? That's where you can get around some strength coaches have huge biases about what movements are the best movement, that everyone has to do this movement because they know this movement. I was like, you got to get over that. Like, there's no one movement to rule them all, right? Unless it's your sport and then you have to do it.
Sorry, your device lost its connection.
Anyway, that was the Google Home. But yeah, so those three phases, positive experience with movement, great exposure, and return to loading. Should, for an athlete who trains a lot, who's into, who has to load themselves heavy or puts a lot of strain on their body, that's generally the way we think about returning to sport after injury. And also, like, those things can be relatively quickly. Athletes might have to bounce in and out. They might be, if they have multiple things going on, right, they can be in different places with different issues. And some people won't go through that whole thing. They just need a little bit of unloading and reloading in certain ways. I hope that's conceptually a different model than what people tend to think, and it's actually a little simpler. But the issue is it's much more open-ended and specific to a person. But again, probably general approaches, like the fact that it takes a few weeks, is good for most people. It's a few weeks of being mindful, but also positive. So that gets you most of the way there.
Yeah, no, I think that's a big thing too, is the volitional exposure to potentially, like, seemingly dangerous, not necessarily dangerous, but seemingly dangerous positions, movements, things like that you were saying, where there is some sort of like fear or apprehension around getting into them. I think that's definitely a really important step, because I've noticed, at least for myself, and also that once I start going into these different positions that maybe cause the injury acutely or whatever, it gives them a different sense of like autonomy, where now all of a sudden it's like, hey, you know what? I was really worried about this, but now I'm, lifting 45 pounds on each side of the barbell, doing a deadlift or whatever the exercise is. And then over time, they're like, this actually starts to feel pretty good. It does give them that sense of autonomy, and they can kind of progress into that. And that sense of, capability as opposed to helplessness is a huge thing for injury recovery anyways. I've definitely noticed it myself, where, especially you go from a really high level of activity, and then all of a sudden you have, depending on the severity of the injury, you're told to stop, and it's like, okay, I have to stop. Like, like you were saying, I remember when I was boxing, I dislocated my shoulder, and I still went into training. I would just duct tape my arm so it wouldn't move, and then I would just do the other hand, and that was really important for me psychologically to get back into it, and really, really helped me out while I was doing some stuff actually back then I was young. I literally didn't rehab it at all, so I shouldn't even say that. I just kind of let it get better. But
funny how that works sometimes.
I was like 16, so I didn't really know any better. But yeah, I definitely think that's a huge, huge thing for keeping people engaged, keeping people motivated, and just actually believing that there is a bit of a light at the end of the tunnel, because that can be pretty debilitating, especially if you are like a competitor and that's something that's a really big part of your identity. All of a sudden having it stripped away, now you're like, well, what do I do? What's going on? Do I have to make changes in my life now? All sorts of things that can be pretty difficult to manage. And then, like you were saying, that kind of feeds into the whole trust factor of coach, clinician, patient, client, whatever it might be. That's definitely a huge factor. And I think even like an adjacent example would be, I've had athletes where during a competition, like let's say a powerlifting competition, I'll be like, okay, here's your next weight, and they're like, oh my god, I don't think I can do that. And I'm like, hey, have I ever picked a weight for you that you haven't been able to hit? And they're like, no. I'm like, all right, so fucking get out there and do this. And that like belief in my level of confidence in them helps them go out there and just smoke it. And sometimes I'll be like, I don't know if they can hit this. Like I'm really confident, but it's a bit of a toss up. But they go out there and their level of confidence is just so high that they smoke it. And you're like, all right, cool. And every coach, every athlete has experienced something like that. But then at the same time, I think they kind of downplay the significance of that in more of a clinical setting, where they're like, oh, I'm in pain, and this person's trying to pump me up. And it's like, that's all bullshit. It's just, huffy or fluffy mumbo jumbo. And it's like, not really, man. Like it's the same basic premise in a lot of ways. And so I think it's
so
sorry, go on.
Yeah, so like that always comes my mind. That always takes me back to the analogy. I think I've heard John Berardi say it. And again, when people ask me like, what do I learn to become a better clinician / coach? I'm like, motivational interviewing and all that like mushy like how to talk to people stuff, right? Because like you just gotta. It's really about people. Once you get some basics down, and John Berardi always said, right, you gotta, the better coach is the guy by the side, and not the sage on the stage. So it's like, right, it's confidence. It's your confidence in your athlete. It's not their confidence in you as some guru, right? Because when you're the guru, you can't express any uncertainty, right? You can't, right? You end up making them dependent on you. They attribute their success to you rather than you inspiring them and them maintaining control over their destiny as an athlete, right? And that's what empowers them to be successful both in the performance environment and also when they encounter a setback, right? Because they can't turn to you because you don't actually have the answers. You can pretend you have answers, right? But you need them to have confidence in your optimism for them, right? Which is different than them having confidence in whatever explanation you have, which sometimes works, but when your explanation doesn't pan out because it falls apart when you make some prediction, then you lose trust.
Yeah,
so yeah,
that's a really important distinction actually, and it kind of goes back to what you were saying earlier, just about kind of acknowledging the limitations of the available evidence right now. It's like, we kind of think it's because of this, and this is likely what it's been in my experience. However, blah blah blah. And I think that does go quite a long way to kind of instill a little bit more confidence, because they're like, oh, this guy doesn't seem to be very ego driven. He seems pretty practical and pragmatic about his recommendations and his treatments and things like that. I wanted to touch on a couple things real quick, just before we kind of run out of time. I wanted to ask about pain during the rehab process, because I have seen some research that shows that individuals who experience some pain during the rehab process actually see better results.
Yeah.
And I wanted just to get you to kind of touch on that a little bit, so people kind of have a better understanding of why that is and what that actually means.
Yeah. I mean, so the evidence that I've seen over the past couple of years is back and forth, but there's not good evidence to suggest that no pain during the rehab process is a goal. That makes any sense as a goal. So the idea is, if there's some pain, it's not the end of the world. And the side effect of pushing into some pain is you get all that graded exposure, you get to load people heavier, you get to show people the other side of pain, that it isn't a disaster, that it's not associated with harm, that it is just a learned response. So some pain might, right, the experience of pain might not help the rehab process. It might be the fact that the pain is associated with some behavior that is more productive, the fact that people are actually pushing themselves, and not under rehabbing. And also the population, it's hard because those populations are different. That's hard to generalize those results. But the idea generally is, don't be afraid of some pain in the rehab process. That's why you also have this pain traffic light thing, where this green light, just 0 to 2 out of pain, like that's fine, right? You're gonna, if you have some sensitivity, you're gonna feel it. But if it's 3 out of 5 where you kind of feel it, but it's not really affecting your movement, but you're kind of worried about it a little bit, but it doesn't change, then that's a yellow light. That's actually kind of just proceed with caution, we say. And then there's when it gets to the point where it's affecting your movement performance significantly, and it might be getting worse, or it causes a flare up the next day. You're like, okay, that's where you cool it. You cool it, down for a couple days. Maybe kind of work your way back to that over a longer period of time. But that's the kind of stuff it would be a good idea to avoid, right? You don't want to just give yourself flare-ups all the time because pain during exercise is good. So I hope that makes sense. So it's a different relationship with pain. That is also kind of goes back to everything we're talking about, right? Any pain is not associated with injury or damage. Pain is not is just as an experience is just not an adequate kind of signal from the body saying it's injured, right? If it were, then none of our pain would make any sense, because we experience many kinds of pain all the time, and we and we experience it at different levels depending upon our stress and how tired we are and what other things we're thinking about. And right, like pain during boxing is different than pain when you step on a thumbtack, right? So how is pain perfectly calibrated to sense your level of injury, right? Right. So yeah. So I hope that helps. Pain is right. Pain is. I think we say in the book, pain is a guide, right? It's not necessarily the enemy, and it's not a zero tolerance thing. And I don't know. I guess clinicians still say that because I don't know necessarily where that comes from. And that kind of goes with the thing of, oh, stop doing anything that hurts forever, as advice from a clinician, which we know is ridiculous. And whenever an athlete hears it, you always get the same thing of, absolutely not. This clinician doesn't know anything. I'm going to leave, and I'm going to prove them wrong. And a lot of times that works, and that's the classic story. So I don't know why clinicians still say it, other than they're just not trained to say anything differently. I mean, I've been around clinicians who said it, and then I would pull the person into another room and say, don't, continue doing what you're doing. It's fine. Yeah, I think it's just it's all part of that change in perspective about pain. And I don't want to be super pain sciencey as a buzzword, but we just need to reframe what pain in the context of injury actually means and how they're related and how they're different.
We talked a little bit about some of the mistakes that clinicians make in terms of how they're framing things to clients, the potential of overutilization of manual therapies and some of those things. So from a patient side, what are some of the things that they do that can be potentially detrimental to the rehabilitation process?
Oh, I mean, that's tough because it's hard because what the patient should do is probably get multiple opinions, right? Because the hard part is, I want to say, do what the clinician says and don't just like do whatever, or don't brush them off like they don't know what they're talking about. I'm going to do what I was planning on doing anyway. It's like, what was the point of the encounter then? But on the flip side is that you could do everything a clinician says and it could be mostly unhelpful, and and it's just the clinician you went to. So I think the standard advice for working with clinicians is get multiple opinions, because when you do, you see that everyone has a different opinion, right? And then you can try to figure out whose opinion you trust more, or if there's common things people are saying that you then think are the important things, and then actually do those things, rather than either doing everything to the T a clinician says because they're your buddy's friend, or they're the first one you Googled, or they're the guy at the gym. And if you tell a clinician, hey, I'm going to get multiple opinions, if they don't like that, they're a terrible clinician. And that means you should leave, right? That's just a great test of like whether someone is confident in their ability and if they know what's best for patients, or they're actually working in patients' best interests, right? If they're not trying to lock you into something. So that's my test for a clinician. I think that's the main thing for me, because I wouldn't want I don't want to assume that the patient will do all this research and like be super diligent and think deeply about, right, the state of the evidence and what the best practices are. Like, they just need some help and they need a guide. And the hard part is finding the guide, that's right for them. And then they need to do what the guide says. But for people doing it on their own, that's a whole different conversation. Which I would then focus more around the fear thing, which is like what like just asking yourself where you have certain beliefs about your pain, you might be rejecting them. And then you have certain beliefs about like what you need to do to be a better athlete, or what you need to do to get back to where you were. Like, how are those in conflict? It was like, what's really driving your behavior, like your decisions around how to get this thing that you're dealing with better? Like, and is that helpful or even healthy? Like, are you a persister or a protector? Like, are you just like fighting through, not acknowledging the fact that there's something might actually be wrong, or something might or something might require some attention, or are you like hyper vigilant and focusing on every little thing because it could be like that injury you had in high school, you know, that took you out for a year. And so I think just the awareness is the starting point for most people, because then they would just moderate their decisions a little bit. Yeah, beyond that, it gets a lot tougher. But I think in general terms, that's where I would tell most people to not be idiots.
Yeah, no, I think that's great advice, especially seeking counsel from a handful of different sources, because like you said, it'd be pretty eye-opening. So we're coming up on that hour mark. I don't want to take up too much more of your time. Can you share just where people can get a hold of you, where people can find you, and also maybe some information on how they can get your book?
So you can get a hold of me on my Instagram, Kaplan Fitness Hybrid. If there's a link to this, we can probably link to it. If you want to get don't get a hold of me for any consultation or for any treatment. I don't do that. If you want to ask a general question, I can answer those. I can maybe direct you to someone who I think would help if you really want treatment and don't know where to look. Yeah, and you can find the book at highperformancemethod.com. There is a link to Back in Motion. You can download it. You can buy it from us there. We will ship to you wherever you are if you're interested in learning more. So generally when people ask me questions, they've already read the book. But if you have questions about anything we talked about, a lot of it is covered in the book in a little less than 200 pages. So it's not like a crazy read. It's accessible to anybody, even if you don't have a medical background or even if you're a coach. But hopefully there are bits that are helpful, even if you are a clinician or student clinician or a coach looking to get better at helping people deal with their pain within your scope of practice. Yeah, other than that, I work mostly on software that helps people exercise now, so it's a little bit different.
Awesome. So all of that stuff is going to be linked up in the show notes. Definitely go give them a follow. Also, make sure you check out Hybrid Performance. They're also putting out a lot of great stuff on a regular basis. And then also make sure you check out that book. Ian and Steffi have been putting out some really, really great information. And I haven't read it yet, but I do plan on getting it once I have a little bit more time.
You've read all the papers that we use.
Yeah. Well, I actually I saw your presentation. So I gave a presentation at KEW as well, and so then I watched yours as well. And so that was one of the reasons I was like, oh, that's kind of cool. That's actually how I found out about the book. But yeah, it was a really great presentation. But yeah, thanks so much for jumping on here, man. It was great chatting.
Yep. Thanks for having me. I appreciate the conversation.